do that. No, you're right. Hello. Hello. Testing. Could we get our food and gather for grand rounds? Come, Olson. Is this actually not working? Who knows? It is working. I can't tell. Hello, Dr. Francis. Hello, Russell. Let's have a seat and get things underway. It's my honor to introduce a colleague and friend, Professor Dr. Marc Bonaca. Marc is here from the Brigham Women's Hospital and Harvard Medical School. We've known each other about 5 to 8 years, and I want to introduce a couple things about you. I won't embarrass you. You can always ask a person what they did for their undergraduate degree. May I? Which was economics and finance with honors. This is a man who likes the numbers and likes to measure things, and his accounting is always accurate, including in science. He attended, got his medical degree from the University of Connecticut, his MPH at the Harvard School of Public Health, has been working through his residency and fellowship at the Brigham and Women's Hospital. He works there both in cardiology and in vascular medicine. There aren't that many of us. Amazingly, this guy has led many of the major TIMI studies that you've read about and we've talked about in Journal Club. And I met you, Marc, at an AHA Emerging Science Series where the best science, at that point, the Vorapaxar early data from TRA2P was announced. And I believe Marc has been the driving force to make sure that all vascular beds are understood and that risk-benefit is understood and that prescriptive benefit can be discussed accurately with patients. So with that background, I'm hoping you'll enjoy Marc's discussion on antithrombotic therapy for secondary prevention. Welcome.
Thank you. It's really an honor to be here, and the hospitality today has been wonderful. I've met with a number of people. We had a really great conference with the fellows just now, so thank you for the warm welcome. So I'm going to talk a little bit about antithrombotic therapy for secondary prevention. I think this is an exciting area because there is something that we can do to modify outcomes for patients that have complex disease and that are at heightened risk. But it's also a very confusing story, I think, and there are challenges as a clinical community about how we apply these therapies as we think about risk and benefit. So I'll go through some data, and then at the end, I'll sort of show a thought experiment that's a little bit provocative, and I welcome your feedback as we kind of think about this particular disease state and these aggressive therapies. These are my disclosures. And before I go into this slide, I'll also mention I added a few personal viewpoints to talk a little bit about my pathway through research so far and academic development. And I always enjoyed when Grand Round speakers would meet with us and talk a little bit about their experiences as a trainee and junior faculty. And so I'll share some of those thoughts, mainly targeted to the fellows in the room, but to everyone as well. So let me begin with just a concept that everybody here is familiar with, and that's risk and how we identify patients at heightened risk so that we can apply our most potent therapies for prevention. And we know from a number of observational data sets and well-done registries, this is REACH on this slide, showing that patients who have established vascular disease are at heightened risk of cardiovascular atherothrombotic events, so CV death, MI, and stroke. And although we have a lot of potent biomarkers and other things out there, really one of the most potent markers that somebody's going to have an event is because they've already had one or they've manifested symptomatic disease in a bed. And if you look at the right panel of the slide, it doesn't really matter which bed you manifest an event in, whether it's a coronary event, cerebrovascular event, or even though it's a minority of patients, PAD only, they're all at heightened risk. And so atherosclerosis is a systemic disease, and those acute atherothrombotic complications can occur with someone in any symptomatic territory. And certainly if you have polyvascular disease, those patients to the farthest to the right, they're at the highest risk for events. And so this is a population that we can target for prevention. And we know that the biology of atherothrombosis is that we have plaque rupture, exposure of sort of an inflammatory lipid core to the circulation, and then there is platelet activation, there's activation of the coagulation cascade and thrombosis, which ultimately leads to downstream tissue injury. This is a cartoon showing the vessel wall here, the lumen of a vessel and a platelet, and several of the targets we have to intervene from an atherothrombotic perspective. And here there are several receptors. This is obviously a very simplified platelets. Platelets are very complicated. But here we have thromboxane A2, the generation of which is inhibited by aspirin. We have the familiar P2Y12 receptor, and we have a number of agents that have been studied that have shown efficacy and for platelet inhibition and modifying outcomes. We have the PAR1 receptor, which is a receptor targeted by thrombin or activated by thrombin, something that when I went to medical school, it was always thought of as in the coagulation cascade, but it really shows the close linking of these processes where thrombin activation or of platelets, also cleaving fibrinogen to fibrin, and also having other mitogenic effects in other tissues. PAR1's expressed in the vascular smooth muscle in the endothelium and has mitogenic effects as well. And so these are some of the available targets we have for intervention when we think of antithrombotic therapy. So what are the data? Well, we know that aspirin is efficacious for prevention of cardiovascular events, whether it's patients with prior myocardial infarction, acute MI, or other high-risk features, including PAD. We see reductions on the order of 25 to 35% consistently, and these are an aggregate of data. There's aspirin at multiple doses. There's even some other agents in there, but we really use this as the justification that aspirin or antiplatelet monotherapy is the cornerstone of our atherothrombotic secondary prevention. And I'll just highlight those patients with prior MI, even in the stable setting. Then the P2Y12 receptors antagonists were studied. There was ticlopidine, and shortly after clopidogrel, which was better tolerated, initially studied for the prevention of stent complications, but then studied here in really a landmark trial, the CURE trial, where it was added to patients presenting with non-ST elevation ACS, so aspirin and clopidogrel versus aspirin alone. And it's important to remember that these were medically managed patients primarily. This was not the prevention of stent-related events, but recurrent de novo events, CV, death, MI, and stroke. And there was a benefit within the first 30 days, but even when you landmark at 30 days and you go beyond, you see that there's continued benefit for more potent antiplatelet therapy with aspirin and a P2Y12 inhibitor. Now, this observation obviously changed practice. We all use dual antiplatelet therapy for patients with ACS. This concept was then applied in a very ambitious trial called Charisma, and I know you had Deepak Bhatt out here not so long ago. This was another landmark trial, but a very ambitious trial. It said, well, we know those patients that have symptomatic disease are at heightened risk. What about also including patients with risk factors, so a very broad population in the stable setting? And it looked at, well, what if we add clopidogrel to aspirin versus aspirin alone? And you can see in that broad population, there was a 7% reduction that was not statistically significant. So technically a neutral trial, but it did have a very important, well, many very important observations, and it raised this hypothesis that in patients who had a prior MI, who had a prior atherothrombotic event, there was a 23% reduction in recurrent events. And if you looked at all symptomatic patients, whether it be PAD, prior stroke, or prior MI, there was about a 12% reduction, which had a nominally significant p-value, hypothesis generating only. But these data really led to this broad hypothesis that patients who have symptomatic vascular disease may benefit from more aggressive strategies. It also led to this concept that atherothrombosis in any symptomatic bed can be treated the same way, and the patients, whether you have PAD, stroke, or MI, are going to have the same risk benefit with these potent therapies. And I think that's something that was a generalization. We'll see that it's a little bit more complicated than that. And specifically, I'll talk about patients with prior stroke. And when you look at observational data sets, they clearly are at heightened risk. But when we look at the risk that comes with potent therapies, we see that there is a differential risk of intracranial hemorrhage. So when you look at dedicated stroke trials, here's PROFESS, MATCH, and SPS3, all looking at dual therapy versus monotherapy, we see significantly increased risk of intracranial hemorrhage. And likewise in Triton, which was an ACS trial looking at prasugrel, a more potent P2Y12 antagonist versus clopidogrel, there was a significant increase in intracranial hemorrhage in patients with prior stroke. And so we start to see indications that although there's a common disease state and there's heightened risk, the response to therapy is not common among these disease states. There's heterogeneity, especially for safety. Patients with prior stroke. Likewise, in patients with peripheral artery disease, the only prospective study in a dedicated PAD population beyond Charisma is a trial called CASPER here, which looked at aspirin and clopidogrel versus aspirin alone, for a broad composite that included limb events and systemic events, and there was no benefit. So here we see, three sets of data that are telling us different things. We see a subset of Charisma where really was the prior MI patients that benefited the most. We see stroke patients that tend to have an increased risk of intracranial hemorrhage when broadly applied multi-agent therapy is given. And then PAD patients where it's more complex and maybe aspirin and thienopyridine is not the answer. And that's manifested in the guidelines. So patients with ACS, aspirin, and a P2Y12 inhibitor for at least 12 months, and we'll talk about duration. Symptomatic PAD, it's monotherapy based on current data. And ischemic stroke, also monotherapy with the exclusion or with the addition of the CHANCE data, which talks about short durations of dual antiplatelet therapy in highly selected patients. Now, TRA2P TIMI 50 is a trial that was ambitious like Charisma. Again, a broad population, type 1 or spontaneous MI, symptomatic PAD, and ischemic stroke. And once again, it asked the question of whether adding an agent to background therapy that inhibits platelets and perhaps does other things would modify outcomes, thinking that these share a common disease state. And patients were randomized to 2.5 milligrams per day of Vorapaxar matching placebo, and they received standard background care. They could get aspirin, clopidogrel, they could get dual antiplatelet therapy, and so on. And it was a long-term follow-up trial with a broad composite endpoint. Now, just to diverge for a second, this is a personal viewpoint. So when I joined TIMI, I was a former research fellow in 2008, and I was assigned to this trial. It just started. David Morrow was the principal investigator and a close mentor of mine. And this really was a great opportunity because I had a clinical interest in vascular medicine, and here was a clinical trial that involved a large cohort of patients with peripheral artery disease. And so this was an exciting time for me. I was very hopeful that this would be sort of a game changer for PAD. I did learn that, for the next 5 years, I was largely doing unglamorous work, calling sites about retention, reviewing safety events. I wrote a narrative for every intracranial hemorrhage that happened in the trial, the projections, and so on. And it was a real lesson that research is not writing the papers. Research is the hard work that happens day to day, but don't let that discourage you because it really is also the fun of doing research. So that was about 5 years of work, and then these were the primary results of the trial. And so when you look at the entire population, there was a significant reduction in the primary endpoint over 3 years of follow-up, and there was about a 13% reduction. There was an increase in gusto, moderate, or severe bleeding. And the bleeding story was interesting. Here, when you stratify patients by whether they had a prior stroke on the left or no history of stroke on the right, again, we see heterogeneity. So lessons from the past with MATCH and PROFESS and Triton, here we see the same story again. Patients with prior stroke had a differential rate of intracranial hemorrhage, whereas patients with no prior stroke had much lesser effect in terms of bleeding. And I'll say personally, for me, having written a narrative for every one of these events, I felt very concerned about this. In the trial, and the patients in red was stopped early because of that risk of intracranial hemorrhage. So again, we see, and probably I think the last trial that will lump all of these disease states together for an antithrombotic agent, the same story again, that they don't respond the same way in terms of risk and benefit. Now, these were the results when you stratify them by, you take out the stroke patients, and here's the primary endpoint. This is grouped together in the pink. Here you see the primary endpoint for MI only, and here for PAD. And the PAD group by design was small. It was about 3,200 relative to the MI cohort, which is about 17,000. And you can see that the confidence intervals cross the line of unity. Now, the correct way to read a forest plot here is to look for heterogeneity. And so technically there's no difference between these two outcomes. These were predefined subgroups. But at the same time, this did not independently reach statistical significance, which was sort of disappointing for me because it's very exciting to work on this trial. And you know, there was a lot of interest in TIMI in this MI subgroup. It was the most viable translation to clinical practice, clearly, you know, clearly beneficial in terms of ischemic reduction. And I'll just say to the fellows here, you know, was this an unfortunate outcome or an opportunity? And I wouldn't be discouraged about complex findings. Actually, a lot of times those are the most interesting studies to work on because you can learn the most, and it really forced us to look closely at this subgroup to understand what was the risk and benefit. And it also showed the critical nature of mentorship because Marc Krieger, who is my mentor in vascular medicine, Dave Morrow at TIMI, really encouraged me to dive into this subgroup and learn as much as I could about them. So these were the results in the patients that when you take out the stroke patients, you group together MI or PAD, and you can see there was a 20% risk reduction with a number needed to treat of 63. There was an increase in bleeding, as I showed you before, gusto, moderate, or severe. There were numeric excesses in severe and ICH, but not statistically different. And these ultimately led to the approval of both populations by the FDA. And I'll say that the FDA did not view these populations differently. In fact, recognizing that there are few therapies for patients with PAD did include them in the label. So we started to dive into the data set and we saw other efficacy signals. One was for stent thrombosis in the coronary bed, and this will translate later to the peripheral bed, but we saw that there was a reduction in definite stent thrombosis. And this includes whether you give it on top of aspirin alone or aspirin and a thienopyridine, there was a significant reduction. And so this is something that was unknown, whether PAR1 as a mechanism would be efficacious for this endpoint. In addition, we looked at stroke. And so although patients with prior stroke might be enriched for lacunar disease or amyloid angiopathy, these patients with MI or PAD and no prior stroke really tend to have atherothrombotic strokes. And we saw that there was a significant reduction in ischemic stroke when we added Vorapaxar to aspirin or aspirin and Clopidogrel. And this, you can see the curves diverge very early, continue to diverge over time. We'll see that pattern mimicked elsewhere. So this is really the first time in a long-term outcome study that this had been observed. Although in Charisma, there was also a signal for reduction in stroke. And then finally, acute limb ischemia. And so we were trying to understand what would be a relevant PAD endpoint for a trial. We've talked about MI and stroke, but these are patients that come to you because their limbs hurt. And Marc Krieger, you can see, is a co-author in this New England Journal paper that talked about acute limb ischemia. And this is truly the analogy of myocardial infarction or stroke, but in the peripheral bed. It's either in situ thrombosis, graft thrombosis, or embolic, and it's one of the most common vascular surgery emergencies. And the outcomes afterwards are dismal. And you can read data from Dr. Hirsch's group that will tell you that the patients that suffer an ALI have long hospitalizations and poor outcomes afterwards. And from a clinical trialist perspective, you know, when you're talking about endpoints in a trial, you want something that is objective, something that is meaningful, that people will say this is an important endpoint to modify, and for a drug that is, at least in part, an antithrombotic, something that you can modify. And so if you look in terms of cardiovascular endpoints, we always include myocardial infarction in the triple composite, whereas things like unstable angina or even urgent ischemia leading to urgent coronary revasc are softer endpoints. You can add noise to your endpoint. They're harder to modify, especially in the era of modern troponin. And similarly in the limbs, claudication, even elective peripheral revascularization, those can be applied variably. They can add noise to your endpoint, where acute limb ischemia was felt to have the same weight in terms of importance and the same potential modifiability. And so this was chosen as a prospective endpoint that was adjudicated. We looked at acute limb ischemia in the trial in terms of did we capture the type of events that we wanted? And the first question was, what's the event rate in a patient with symptomatic PAD? As a cardiology fellow, I did not see a single patient with acute limb ischemia. I thought it didn't exist. And that's because in the middle of the night when they showed up, they called a vascular surgeon. They didn't call me for obvious reason. But it really gave me the false impression that this doesn't happen. And here we looked at annualized event rates for the patients with symptomatic PAD. And you can see for a patient that walks in your office and they have symptoms, they've had a revasc, they're as likely to have acute limb ischemia or amputation as they are to have unstable angina or an ischemic stroke. And the rates, even for non-CV death and myocardial infarction, aren't so different. So this actually is quite a frequent event in a symptomatic population. We then asked what were the reasons for it. And you can see in this cohort, about 2/3 had had a prior revascularization. Most of it was surgical graft thrombosis, followed by native vessel thrombosis. Stent thrombosis was relatively rare, and then thromboembolic. And I'll point out that if you look at registries, you'll see a somewhat different distribution, particularly this blue wedge. And that's because we excluded patients with atrial fibrillation, right, because they had to be on an anticoagulant. And so thromboembolic events were rare here relative to others. Finally, we looked at what happens to patients who present with ALI as captured in a trial. And you can sort of mentally compare this to what happens to a patient who presents with a myocardial infarction. Over 3% died during that hospitalization, 17% had an amputation, a third needed an ICU stay, about 2/3 had surgery, and the median hospital stay was 8 days. And at the end of the hospitalization, about 15% had either died or were unable to go home and live independently anymore. And so when we think of meaningful outcomes in cardiovascular trials, what matters to patients, these are pretty bad outcomes, especially when you think relative to what it is for myocardial infarction in the modern day. Finally, we looked at whether the drug modified these outcomes. And on the left side of the slide, you'll see hospitalization for acute limb ischemia. And similar to ischemic stroke, you see that there's a reduction early on that continues over time. There was about a 42% reduction that was statistically significant. And then we saw something unexpected on the right side of the slide, that even elective peripheral revascularization was reduced. It was reduced by about 16%. This was an exploratory endpoint. But you can see that the pattern of the curve is very different, that there was almost no signal of efficacy for the first year and a half or so, and then that the curves later diverge. And I'll tell you, as we drilled into these data, we see that the revascularization for claudication actually was reduced. And we're not quite sure what the mechanism for that was, although some have hypothesized that PAR1 effect on the vessel wall may be partially responsive. It may not be all an antiplatelet effect. So I presented these at the Emergent Science Series. I was junior faculty. I met Alan Hirsch for the first time, although I'd heard his names around the halls of the Brigham many times. And it was a real lesson to me that people outside your institution can be outstanding mentors and can provide important perspective and support. And that one meeting, where we discussed this trial has sort of blossomed a mentorship relationship and a friendship that has been very, very important. So from the TRA story, the addition of a PAR1 antagonist provided benefit. There was bleeding. Patients with ischemic stroke did not benefit and had increased risk of ICH, a story we've now seen multiple times. And patients with MI had the greatest MACE reduction. Patients with symptomatic PAD had reductions not only in MACE, but also in important limb events. So around the same time this was ending, I started as the co-PI on Pegasus TIMI 54. I did different mentor for this, Marc Sabatine. And this was also while closing TRA and doing a vascular medicine fellowship. And I'll tell you, you can definitely spread yourself too thin, and it's difficult to balance. But when you have sort of multiple things going on, sometimes they bear fruit at different times, and it's important to try different things. My only advice is that make sure your mentors are supportive of the big picture, and mine definitely were, so they understood the time pressures of doing multiple things at once. And this brings us to the sort of post-MI long-term DAPT question, which is slightly different than TRA's question. Here's the DAPT trial, and I know that you heard about this in an earlier grand round, so I won't dwell on it. But here, Laura Morey and others asked the question of, well, if you do coronary stenting and you treat for 12 months, the patients are tolerating therapy and they haven't bled, what happens if you continue it at 12 months, up to 30 months, that's in the green, versus withdraw therapy, and that's in the blue. And they showed that withdrawal of therapy at 12 months was associated with worse outcomes, and continuation reduced death, MI, and stroke. There were some nuances to the results here. There was an imbalance in mortality that was largely driven by elective PCI patients versus patients who had ACS. And there was an increase in bleeding. At the same time, we were doing Pegasus TIMI 54, which actually asked a different question. Instead of withdrawal after stenting, this design was really, if we take stable patients with a prior history of MI, If we sort of boil down and distill charisma to that one subgroup, and we pick high-risk patients with at least one high-risk feature, and we give them aspirin and either one of two doses of Ticagrelor versus placebo, will there be benefit? And so this really was a pure secondary prevention trial in stable outpatients with a history of MI. We used the 90 milligram Ticagrelor dose that was shown efficacious in the Plato trial, and a lower dose that we thought might have the right balance of efficacy and safety in stable outpatients. And here you can see the primary endpoint of Pegasus TIMI 54. You can see one thing I've learned at TIMI from Dr. Brumwald, and I'm sure you've all heard the same thing, is that when you look at a curve like this, you always look at the placebo curve first. What is the natural history? And one thing that's interesting here, and you see it a little bit in TRA, but it's quite striking, is that this is a chronic disease, right? I mean, there's no inflection point in this curve. If you look at the AFib trials, you look at any of the NOAC trials, you see the same pattern. It's linear relationship. Whereas when you look at ACS trials, you really see a curvilinear relationship. There's heightened risk early and it plateaus over time. But here really there is an ongoing disease state, which was the hypothesis of the trial. And then the second part of the hypothesis was, could we modify it with long-term potent antithrombotic strategy? And you can see that both doses significantly reduced the primary endpoint. What was surprising was how similar they were in terms of their efficacy, even for a dose that provided 2/3 the exposure of the other dose. But both doses look very similar. The other thing that was important for us to observe was that for each of the components, there was consistency. And similar to TRA2P, we see that there's a significant reduction in ischemic stroke. I'll point out that this population excluded patients with prior stroke, learning from Pegasus, learning from TRA and other trials. It was a very selected population. But there's consistency for all of these endpoints, meaning that the benefit of therapy was not just to reduce recurrent MI, but actually CV death and stroke as well. There was an increase in bleeding. There's no free lunch. TIMI major bleeding was significantly increased, as was TIMI minor. There was no imbalance in ICH or fatal bleeding. So this was another complex finding. The absolute risk reduction in the primary endpoint is similar in magnitude to the absolute risk increase in TIMI major bleeding. And I'll say there's been a very mixed response from the clinical community about these two trials, about DAPT and Pegasus. Should we be doing this for all of our patients? And maybe people just raise their hands. How many people continue dual antiplatelet therapy indefinitely after MI? How many stop, or how many use it long term? Okay. And then how many people stop at 12 months? Yeah, so sort of an equal number of hands. And I think this is a complex finding, right? I mean, these are TIMI major bleeds. They're not inconsequential. And I'll say after dedicating 6 years to the trial, I, of course, was very personally invested in the results, but it's important as a lesson to me was listen to critics and learn. I mean, there were important points being raised here. Don't be personally invested in it really is the science that matters. And actually, just like TRA, complex findings can be an opportunity because I think it pushes us to learn more and to do more. And I think it was, the Pegasus story has become actually much more interesting than if the result had been straightforward. I'll say that our trial was grouped together with a series of other trials looking at post-MI patients. This was done by Jay Udell, who is a fellow with us and is now back in Canada. And here you can see that overall there was a reduction in the primary endpoint, and this is specifically cardiovascular death. So when you group all the trials together, continuation therapy does reduce cardiovascular death. And here you can see all of the components when you do this as a large meta-analysis are reduced with long-term dual antiplatelet therapy versus aspirin alone. And as I showed before, there's more bleeding, major bleeding, but again, even in a large meta-analysis, no difference in fatal bleeding, ICH, or all-cause mortality. Now, it's interesting, please interpret this slide with caution. You can't really do cross-trial comparisons, but within a trial, you can look at the absolute magnitude of increase in risk. And so I'll just show you, here's charisma and gusto moderate or severe bleeding. You get about 0.5%, this is per year, increase in bleeding. In DAPT, you got about the same thing. In TRA2P, this is the prior MI subgroup, you get about the same thing. In Pegasus TIMI 54, again, 0.5%. And so I think broadly, this is the price that we pay, is about 0.5% per year in major bleeding, not ICH or fatal hemorrhage, but there is a price to pay, and it's relatively consistent among all of the trials. So then I want to transition to talk a little bit about a thought experiment. How do we integrate all these data? We've had 3 large trials. We've had TRA2P, DAPT, and Pegasus, all show that when we add a potent antithrombotic, a P2Y12 antagonist, a PAR1 antagonist, or both to aspirin, that we reduce ischemic events. We prevent MI, we prevent strokes, we reduce CV death, but we cause bleeding. And how do we balance these 2 factors? And so here's just a way to extrapolate some data. So if you take 1,000 patients and you treat them for 3 years, based on the ATT meta-analysis for aspirin, you would prevent about 30 CV death, MI, or stroke events at the cost of 13 major bleeds, mostly GI, but there is an increase in intracranial hemorrhage with aspirin. This is the price we pay for aspirin monotherapy. When you add a second agent, and whether it be Vorapaxar or Ticagrelor, again, generally, you further increase it by about, the reduction by about 14, so you get about 44 CV death, MI, or stroke events, and you increase 9 major bleeds. This is the ICH from aspirin. And so here is your risk benefit from a potent strategy in a patient with prior MI. And actually, when you look at that, it's not so different than what we do for atrial fibrillation. So on the left side of the slide, you take a 66-year-old person who comes to your clinic, feels well, but tells you they've had a prior MI and no prior stroke. Their annualized risk of an event is about 4%. And I just showed you how you arrive at about, if you decided to put them on a multi-agent strategy, you prevent about 44 events for 22 major bleeds. Now, if you take the right side of the slide, you take a 66-year-old man with atrial fibrillation and hypertension, CHA2DS2-VASc score of 2, their annualized stroke rate is 2.2%. So you add warfarin to them, and you prevent about 44 ischemic strokes at the cost of 36 major bleeds, including 6 intracranial hemorrhages. Now, if you chose a NOAC, your major bleeding rate would be lower, and you'd cut that ICH risk in half. But actually, when you stack these 2 against each other, they're not so different, this risk-benefit. And so I asked myself a little bit of why was the response to DAPT and Pegasus so controversial, where we all accept that we're going to treat that patient on the right side of the slide with warfarin. Well, in part, when you think about it, we have risk stratification tools for patients with AF. We can quote an annualized event rate. We can say, this is your risk of stroke, and although I know you're going to have bleeding, I know how many strokes I may prevent. And as the CHA2DS2-VASc score increases, the benefit of anticoagulation increases. So patients at higher risk are getting greater benefit. We don't really have that for stable patients with prior MI or with PAD. But the important thing is that CHA2DS2-VASc and many of those elements actually overlap with bleeding scores. So when you stack up CHA2DS2-VASc, has-bled, and hemorrhages, you can see a lot of common factors here that predict bleeding as well. And so when you actually look at risk in these patients, here, if you look at CHA2DS2-VASc, as you go from 2 to 3 to 4, you are reducing the number of ischemic strokes that are occurring, or you're getting greater benefit, but you're also causing more bleed. So there's, again, no free lunch even in atrial fibrillation. It's very hard to separate ischemic risk from bleeding risk. They tend to travel together. So how do we apply our therapies? Well, one thing that we're trying to do is to look at subgroups and risk scores to try to help us inform this population, as we have with atrial fibrillation, of who derives the greatest benefit at the least risk. One thing we've explored in Pegasus is this concept of withdrawal. When you look at the DAPT data, it's very interesting that in the intervention group here, which was really withdrawal of therapy, you can see a very steep inflection of the curve early that tends to plateau over time. And in the group that were continued on a P2Y12 inhibitor, when they withdrew therapy here at 30 months, you see again, they start to catch up with the blue curve. So is there a withdrawal effect? Not a rebound, but are you unmasking disease and allowing those patients to have events? So we did the same analysis in Pegasus TIMI 54, and these data were presented at the ESC and published in EHJ. And when you stratify patients based on the time from the last dose of a P2Y12 inhibitor when they entered Pegasus, you see a similar relationship. So patients in the red were patients that were on Clopidogrel or another drug, and they randomized in the trial and it was withdrawn. these are placebo patients that were withdrawn from therapy. In the orange and the yellow, these were patients that had a last dose between 30 days and 1 year, more than 1 year. And here you can see that there's a clear relationship with risk. Those patients that were withdrawn on randomization had much higher risk of an event in the first 90 days, and even after adjusting for all the differences between these groups, there was significantly higher risk. So withdrawal of therapy may be associated with heightened risk. And then the question we had was the benefit of therapy modified by this factor? And actually there was a significant interaction. So you can see that for patients that were withdrawn versus continue on, there was a robust risk reduction of 27% with both doses. For those that had been on a P2Y12 inhibitor between 30 days and 1 year before entry, there was a more modest relative risk reduction of 14%. And so patients who had been off of clopidogrel for more than a year and done fine had no benefit. And so this is sort of, you have to think about this for a second, but to get into the trial, you had to do well. If you were doing well for more than a year on aspirin alone, you had selected yourself out as a survivor. You were by that nature a lower risk patient, and adding back therapy later really didn't provide much benefit. But for the patient that came to clinic at 12 months and they were doing fine on therapy, withdrawing it was harmful, and continuing it was associated with a significant benefit. And so there's one analysis that we thought potentially was helpful in the clinic, because prior MI population is very large, that continuing on between DAPT and this subgroup appears to be one strategy that may be beneficial rather than adding on to everybody. And this was completely independent of time from their MI. These are patients who had an MI more than 2 years before randomization. And even for them, if they continued on, it was about a 30% risk reduction. So one lesson for us was that this may be a population you choose to continue with a potent strategy, and that withdrawal may not be benign, even if patients are far out from their event. Another subgroup analysis were patients with renal dysfunction. This is from Pegasus, and we saw patients with renal dysfunction have a higher risk. Again, look at the green curves first. This is the natural history. So patients with normal renal function, this is their 3-year event rate, and with abnormal renal function, they have about a doubling in the event rate. The effect of the drug is the same, but by nature of their higher absolute event rate, they have a much greater absolute risk reduction with therapy, and a number needed to treat of 37. That's another subgroup of potential benefit. In TRA, there have been similar analyses. So this was patients with diabetes, very similar to renal dysfunction, where there's a doubling in terms of their natural history in the event rate, and a more robust absolute risk reduction in a number needed to treat in 30 in patients with diabetes and prior MI. And then finally, patients with coronary artery bypass grafting or multivessel disease seem to have a more robust benefit as well, with a number needed to treat of 27. So we're starting to see subgroups where hopefully people can say in my practice, maybe these are patients that I would choose a more aggressive strategy for. So in some observations, so the broad hypothesis, just going back to the beginning, that patients with symptomatic vascular disease will have a similar response to therapy, I think really has been challenged. This was something that was born out of registries like REACH that was tested in Charisma, it was tested in TRA, but we really have learned they respond to therapy differently. And I think we have to be thoughtful as clinicians that patients that have had a non-embolic ischemic stroke, they're really a diverse population. There's differing biology of stroke, lacunar stroke, there's versus large vessel athero, and they may enrich for comorbidities of bleeding like amyloid angiopathy. And I think that lumping them together with these other populations does them a disservice, because these safety events are rare. Intracranial hemorrhages are rare, and you need a well-powered trial to really understand whether there's a safety event. So just having 1,000 patients with prior stroke in a big MI trial is not enough to tell you that the drug is safe, and we've learned that now in multiple trials. So really, dedicated stroke trials are necessary. In the same way, patients with symptomatic PAD, they really face a different morbidity. Yes, they're at heightened risk of MI and stroke, but they're also at heightened risk of limb events. So lumping them in an MI trial where you're only looking at ischemic stroke and MI without looking at limb events really does them a disservice. It doesn't look at the full picture of efficacy and safety, and therefore really dedicated PAD trials are necessary to understand the risk-benefit of these agents. And I think from the existing data sets, these patients with history of MI, they appear to derive the most favorable benefit from a MACE perspective from prolonged intensive therapies. So the risk-benefit of DAPT or triple antiplatelet therapy with aspirin, clopidogrel, and Vorapaxar for long-term secondary prevention in patients with prior MI, it's really similar to what you get with warfarin for a patient with AF and a CHA2DS2-VASc score of 2. Something I think we'd all accept in our clinic as what we have to do. So why do we struggle with the concept? Well, one thing I've thought about is it apples versus oranges? I mean, we all know ischemic stroke is really bad. Maybe we're not so sure that recurrent MI is so bad. Maybe we think these sort of troponin leak, they get a PCI, they go home the next day. Maybe that's not so bad versus a TIMI major bleed. Maybe that's part of what is giving people concern. There's also the concept of event-related risk, decreasing with time. We think of AFib as a chronic disease state. We know that atrial appendage can form clot at any time, form a stroke. But I think intuitively we still feel that once you're a couple of years out from your MI, your MI-associated risk is gone. And I think that's been challenged. I think that we really understand that an MI is a sign of an underlying disease state that is a chronic disease state. And I think ultimately we need better risk stratification, risk scores, biomarkers, and genetics. So my personal reflections on the data, I think the long-term strategy after MI is no longer to protect the stent. It's clearly to protect patients from de novo events. I think there's been a paradigm shift for chronic secondary prevention for MI and PAD, and maybe AF is a reasonable model to consider. I do think we should be discussing the risk and benefit with all patients. To me, in my clinic, for patients that come in a year after MI, they're on dual antiplatelet therapy or triple antiplatelet therapy. They're not having tolerability issues. They haven't had bleeding. I really consider continuing unless there's a reason to stop, rather than the converse, which was what I used to consider. But I do think for the patients that are out there, years after MI, doing well on aspirin monotherapy, I don't routinely reinitiate therapy. I continue aspirin monotherapy unless there really is a high risk feature that I'm concerned about. And there are some risk scores under development. I'll just briefly show, this is one that we developed at TIMI out of TRA with very common risk indicators, and you can see the hazard ratios there. This will look very familiar to you because it's very similar to other risk scores. And when you look at the risk in the placebo group with increasing score as a nominal score, you see that it does differentiate risk quite clearly. And interestingly, when you look at the risk benefit of the drug, when patients with a score of 0, 1 to 2, or 3 or greater, you can see that the number needed, there's no benefit in low risk patients, the number needed to treat of 48 and then 31. And interestingly, the bleeding risk is highest in the low risk patients, where we see less increase in gusto-severe bleeding in the higher risk patients. So this is preliminary work, but I think it's the way that we have to go to try to understand which patients will benefit from these therapies. So I'll just say on the last slide here, this is where the real fun is. There's ongoing work by multiple fellows in our group, people external to our group, collaboration with the DAPT investigators, collaboration with Dr. Hirsch and his group. I'll say that being a mentor now, having been a mentee for many years, is extremely rewarding. It is incredibly fun. And likewise, to share, collaborate, and build relationships outside of your institution, that is great too. And I think, there's a tendency to say I worked for 6 years on this project and it's mine. That really is not the way to go. I mean, I think when you all share and work together, you learn from each other and you develop some really great relationships and have a lot of fun. And just remember that the mission is just to improve care and not get too wed to your results, but really try to find the truth. So thank you, and I want to thank specifically Alan and everyone here at the University of Minnesota. It's been a wonderful trip so far. Thank you.
Are you willing to take questions from the very erudite Minnesota crowd?
Yes, please.
Let's start. Yeah, oftentimes when patients come in with an MI, they were prior to that they were healthy, not on any medications, and then all of a sudden they have this MI, and the next thing you know, they get a stent, and you're talking about aspirin, Plavix, Vorapaxar, 3 other medications. So I think that's often hard, and then there's that leap of faith when they leave the hospital and they're going to take all these. So do you have any advice as to how we can explain to the patient that these are all important and there's need to take all these medications?
Yeah, I think it's a great question. In fact, we presented some data at the AHA about tolerability and compliance with Ticagrelor in Pegasus, and the discontinuation rates in the stable setting were much higher than observed in Plato in the acute setting. So I think that one thing is that the patients that come to the hospital with their first MI, I mean, it really is a wake-up call for many of them to modify their behaviors. It's very different than a patient who feels well in the outpatient setting. You're trying to add drugs on. It was the commentary from the Sprint trial. If your patients aren't going to thank you by adding another blood pressure medicine. I think at the time of a myocardial infarction, there is an opportunity to sort of tell patients that this is, long-term risk. You've had a real event. And so you should use that opportunity to talk to them. I also think that you're not going to know. I don't decide on the duration of antithrombotic therapy when they come in for their MI. I think that is just like any patient where you're considering long-term therapy, including somebody who's had an idiopathic PE, right? You may think to your mind, I think long-term therapy, but you have the patient come back in a month. How are they tolerating therapy? Have they had a bleeding problem? 6 months, a year, and so on. And it's really the patients who are doing well that you're going to continue. If they have a major bleeding problem or a tolerability problem, you may not. And so I try not to overwhelm them with the big picture, but I really try to talk about risk reduction and say, stay on it until our next visit, and then we'll talk more about it, counsel them that way. Yes, Quinn.
A lot of these patients have stroke. How is correct for stroke in patients in the longer term?
Yeah, that's a great question. So I don't screen routinely for prior stroke. All of these trials only excluded patients with clinically overt stroke. And it's a good question. If we had a good blood test for amyloid angiopathy, I'd love it, because I think that it with our anticoagulants as well is a problem. But I think in the way I apply these data is as it was in the trial. Yeah.
You presented convincing data that long-term dual antithrombotic for patients with MI. How would you compare the patients with coronary disease and the Stenting? For example, somebody coming in with an angina, Stent for them,
Yeah.
and they are on dual therapy. Would the data be pretty comparable to those who personally have angina?
That's a great question. I personally feel that there's a difference between a patient who has stable coronary disease and has never had an atherothrombotic event compared to a patient who's had an actual MI. I think that there are different disease states, and to some extent, and the risk-benefit of therapy is different. I think DAPT really showed that nicely because the DAPT trial was positive overall, but Bobby A had a subsequent paper in JACC which really showed that the greatest benefit were those in prior MI. Those who went in for elective stenting for symptoms, the risk-benefit was more complex in that group, and so I don't routinely apply this concept to patients who have not had an MI.
I'll ask a question. Marc, you've obviously shown the evidence that there's clearly net benefit, but there's a risk to buy-in that the greater amount of risk factors or endogenous risk, you get more bang for your buck. We're all rushing around. Every visit is quick, and we tend to react emotionally to, oh my God, you might bleed. How do you engage that discussion so the patient can participate in the decision? Because I think we often make the decision ourselves and don't let the patient really judge that risk benefit. It's very personal.
Yeah, that's a great question. I think in general, my sense, and I'm happy to take other viewpoints, is that as clinicians we're conservative and we don't want to cause a problem, especially in a patient who feels well. So I think we, as clinicians, are fearful of bleeding because a patient that comes to the hospital with a bleeding event is scary, and they can say, you gave me this drug and I had a bleeding event, whereas they don't thank you for the MI or the stroke you prevented. Nobody knows that it didn't happen in a sense. But I think patients do feel differently, and there are actually some data from John Spurtis and his group where they actually asked clinical trialists and then patients about how they would weight different events in terms of, if you have a certain amount of points to give, what do I want to avoid the most? In clinical trialists, all clinical trialists really cared about were all-cause mortality and things like bleeding and so on. But when you look at patients, young patients want to prevent mortality. Older patients, the ones that we're talking about, most of them, they would weight a stroke or a myocardial infarction more than mortality. They're not trying to necessarily cheat death. What they're worried about is disability. and they're worried about losing their independence and their quality of life. And so I do think that we do our patients a disservice by prejudging what they would want. And I talk to them about it and say, yeah, you know, there's a risk. Most of these bleeds are GI bleeds. You could come into the hospital, could be scary. On the flip side, an ischemic stroke or myocardial infarction and the things that can follow with heart failure and so on, those aren't good either. And I've been surprised by how diverse the reactions of patients are. So I think you have to have the conversation, and we shouldn't assume what matters to us matters to them. And I think we have to fight that concern that if we cause bleeding, we did something bad, because we have good data to support the ischemic benefit of these therapies.
One or two more questions? That's a logic question. How he got all that done while actually being a fellow or having a child? Personal observation? Dr. Krasner?
What made you switch from economics to medicine?
Yeah.
He didn't really switch, did he?
Yeah, no, it's a good question. So I actually, I had been interested in doing medicine all along, to be quite honest. I did all my pre-med work in college and took the MCAT. But, you know, I kind of wanted to go out and try something and see a little bit of the world. And you know, it's interesting you asked the question. I went into economics and finance. You know, I did all my pre-med stuff. I wanted to have those skills, and I ended up taking a job with Price Waterhouse initially as a consultant. And my first project was here in Minnetonka at Cargill, doing programming for credit risk systems. And they sent me to London and Singapore and stuff. So for a couple of years, it was an interesting life. But I'll say it taught me a lot about, you know, professionalism in the real world. And when I finally made the decision to sort of put all that aside and go to medical school, you know, there were a lot of skills that I learned that were helpful, not only computational skills, but also, you know, the real world skills of what people expect from you, and professionalism. So, but ultimately it was because I wanted to broaden my sort of skill set. You know, wasn't a true change of heart.
Quiet audience. Maybe we should simply say thank you. It was a great case conference, and I appreciate you being here. You'll be here tomorrow as well.
Thank you.
Great talk.
Oh, thank you.
I really enjoyed looking at your CV.